Thanks very much, and thanks for having me along. Thanks to everyone who's attending, and apologies to those of you who tried to attend the last time this session was scheduled, but had to be cancelled for a variety of reasons, so apologies for that. So thank you for the introduction. So what I'm going to do is to take you through really a case study that will begin to think about these questions around disease prevalence and access to particularly palliative care. And as well as a case study, we'll think about a possible agenda for future research, which will hopefully interest most of you present. So let's start at the beginning. As I've said, this it's not going to be a comprehensive overview of how we understand disease prevalence in Northern Ireland, given that's the geographical focus of this piece of work, or access to healthcare in general, or palliative care specifically. Instead, it's going to be driven by a case study that will hopefully enlighten you in terms of the kinds of things that we can do in addressing these sorts of questions. So how do we better understand the characteristics of disease incidence across the geographical area? How do we think about provision of care that will be targeted at particular groups who need that care? So we'll do that through a case study, but as I said, there'll be a few general points, hopefully, that you'll be able to reflect on. So what we're interested in, first of all, is the spatial distribution of poor health. So in this particular case, where are people with particular health conditions? Are they geographically concentrated in particular areas? Are rates changing across time? As it was outlined in the introduction, I'm particularly interested in change through time. So it might be that rates of a particular condition are increasing, or as I'll go on to discuss later on, the characteristics of the population more generally are changing. So you might have an aging population in an area which will be associated with particular needs. So the spatial distribution, the geography, if you like, of poor health is a key focus. And then thinking about need and accessibility. So do those people who need access to care, do they have it? Are there members of particular groups who are geographically distant from the kinds of care they'd need? Whatever care might be. We might also think about community support services of various kinds, as well as primary care facilities. So there are lots of different ways we can conceive of this. And then there's a particular focus on identifying gaps in provision. And I should say, this piece of work I will introduce in terms of the funding and where it comes from, but it's part of a wider programme of work, including a collaboration that I have with the Public Health Agency in Northern Ireland at the moment, looking at gaps in funding. So which particular areas have less access to community-based funding, for example. So I'll talk a little bit about those sorts of themes. So access to healthcare is particularly important, accessing what we need, which areas and thus which communities are most distant from facilities or maybe investments of some particular kind related to health, and where need is greatest. And obviously that can be tailored to particular groups. The example that I'm going to be talking through at some length relates to dementia, people living with dementia, and I guess their families too. And we would think in that case about those members of those groups who are distant from support services. And then in general, there's an issue around spatial inequities or inequalities in access for particular groups. In this case, we're thinking about older people. So the case study that I'm going to use to try to talk through some of these points, I mean, I'm hoping the case study itself will be of interest, but also, as I've said, it will open up a number of issues that we might want to consider going forward. So it's Northern Ireland based, it's funded by Northern Ireland body, and for a variety of reasons it focuses particularly on Northern Ireland, not the whole of the island of Ireland. But I will say a little bit later on about the potential to extend some of this work, given that poor health doesn't stop at the border, or access to resources or need doesn't necessarily stop at the border. It's largely driven by data and a number of other issues as to why we would focus on this particular area alone. So it's not a general study of palliative care, but the sorts of approaches I'm going to talk about could be expanded. There are a variety of initiatives out there that could be linked to or built upon as well. So moving beyond dementia or related conditions or aging of populations in areas, it could include an array of different diseases or access to any kind of healthcare resource or community facility or whatever we might be interested in. So I will end by talking about some potential ways that we could build a resource that would help us to better understand the geography of health and healthcare and need, initially in Northern Ireland, but potentially across the whole of the island of Ireland. Now, just a bit of very timely update, I guess. If we think about dementia, obviously, one of the key things we might think about are older people, not exclusively. There are groups who are more likely to suffer from dementia, but certainly age and aging are common concerns if we think about dementia. So some of you might have seen today, NISRA, the Northern Ireland Statistics and Research Agency, have just produced the first outputs from the 2021 census, literally today. So it's very, very good timing. Those outputs are just on age breakdowns, and there's a bit on average household sizes and things like that. There's nothing on, for example, health conditions, or, as would often be of interest in Northern Ireland, on community background and religion. None of that's released yet, but some of these headline figures are. And one of the interesting things that they highlight relates to the breakdown of the population by age. So we've got, in this particular table, we've got a number of different years of either census data or mid-year estimates, which are basically updated using a variety of sources. And we've got the breakdown of the numbers of people in these broad age categories, 4 age categories, and then I've got the percentage who are aged 65 plus years. And as you can see, in 2021, the column in bold, we've got the largest percentage of the population by some way. There's quite a clear percentage point leap between 2011 and 2021. And from NISRA's press release of today, population increase was greatest in the older age groups. So the number of people aged 65 or more rose by over 60,000 to nearly 1/3 people. So this is a near 25% increase on 2011. And we're seeing this because of the baby boom generation of the 50s and 60s reaching retirement age. And this trend seems like to continue. So this is only obviously one part of the picture. Of course, there's lots of other factors we'd have to consider, and lots of other groups, or many groups who are affected by dementia in a variety of ways. But I thought, just given that this was so timely and literally the press release had to come out today and the data happened to come out today, it was an element that it might be worth reporting on. So thinking about this particular class of health conditions, so thinking about people living with dementia, one of the things that I'm particularly interested in, as I've said already, is the geography of inequalities, and in this particular case, health conditions, and in this very particular case, dementia. So in an ideal world, if we were going to understand need in terms of dementia, we would obviously have geographically detailed information on dementia cases and rates, so that we could say something about where services might be required. So one of our key focuses, as I'll say a little bit later on, was on rural areas where physical access might be more distant to primary healthcare, to community groups, to whatever. So that's the first thing we would need. If we're concerned with the geography of any health condition and accessibility to healthcare, we need geographically detailed information on that health condition as a starting point. But in Northern Ireland, dementia rates are not, or counts and rates are not freely available for small areas, at least not for residential areas. So by small areas, I mean something like super output areas, which in Northern Ireland, there are 890 of those, and there are just over 2,000 people in each of them. So these sorts of areas, or wards, or census tracts, or other units that are used in different places, but that's what we mean by small areas. So because we don't have these data, and I'll come into what we do have a little bit later on, we need to estimate dementia rates, or use some proxy for dementia rates that we could use to better understand the geography. Another focus of the project that I'm going to introduce to you is on age and aging. So aging, obviously, I mean, in this case, do we see the age profile of particular areas becoming relatively older, and what implications might that have for services that relate to the process of aging? And then obviously there's an interest in this level of demand for health and social care services, particularly, though not exclusively in this case, for older people, and thinking about how this is changing in neighbourhoods across Northern Ireland. So where is demand greatest, and what kinds of places where we might see the greatest need, and where might that be changing? Where might there be, for example, as a proxy, a not very good one, but as a proxy, where do we see aging populations, and thus what implications might that have for a variety of different types of services? Might it be that we see certain areas falling behind because the services are ever ever less suitable or sufficient, I guess, for the population and the nature of the population change that we see in those areas. So this all comes from a project that was called an analysis of dementia, mild cognitive impairment and aging for the understanding of future care provision within rural areas of Northern Ireland. So that was the original project. As it says here, and as I think it says in the descriptions of the seminar, it was funded by the Department of Health here, sorry, the Executive Office and Atlantic Philanthropies as part of DARUG. And I think there were probably one or two people associated with DARUG who were sitting in on this seminar. So that's Dementia and Analytics and Research User Group, for which there were a variety of different projects that used data connected to or on dementia to try and enhance services or to understand better the nature of need. So what we aim to do is to link data on age, again, accepting that age is not everything when it comes to dementia by a long way. So linking age and dementia to try to understand the geography or the spatial patterning of dementia and aging within Northern Ireland with a focus on rural areas. The kind of long-term aim, which we started to move towards, is to have a resource that would let people, whether that's community groups, individuals, or even healthcare professionals, to understand where need is, where it might be changing, and what sorts of resources or facilities are available in particular areas. So how well does that map onto the need? One, I think I should just say, I can see that there are comments coming up in the chat. Unless anybody really wants to insert with a question on in the middle, I can deal with those at the end, if that's okay. But I can go through those systematically. So if there's anything that you wanted to ask, I will go back to it. So the aim is to develop a resource that enables people to basically work out where need is and how it might be changing. So what we've done briefly, and then I'll obviously go into this in a lot more detail, is to link data on age and dementia, though this is through an estimate, and I'll talk about that process a little bit later on and how we might expand on that specifically, but also to include other health conditions. So we've looked at, for example, associations between dementia and aging, and this is obviously only an ecological analysis. We can't look at this using individual level data. We only have data for the geographical areas. We've also linked in other demographic and socioeconomic variables. So deprivation, for example, in Northern Ireland, the standard measure of deprivation is the multiple deprivation measure, last released in 2017. I know there are equivalent deprivation measures in the Republic. So the same idea that you have something which encapsulates lots of different forms of deprivation, from unemployment through to health to crime, potentially a variety of different aspects. Then also things like housing tenure and a variety of others. And then also health status and outcomes. So using GP registration data, for example, you could potentially link in other data on prescriptions and so on and so forth. So what we've hoped that we've been able to do, and that we hope to do even better in the future, is to better understand something about the geography of dementia, or at least dementia risk across Northern Ireland. So we've also linked in healthcare services, so GP practices, pharmacies, dentists, etc., so that you can look at accessibility to primary care. And as I will talk a little bit more about later, there's potential to also link in all kinds of community-based services, for example. So we've developed a publicly accessible mapping tool, and I'll say a bit more about that later on, and I'll show you that in practice. This is just a very brief outline of what the project entailed. There were 4 work streams. The first to look at aging, as you can see under S1, the second to look at dementia rates, and I'll talk about the problems associated with that in a minute. The third to look at associations between dementia, age, and then a variety of other population and housing characteristics. And then the final one was to think about access to resources in connection to those previous themes. So that's more or less what the project set out to do. Now, the first thing I wanted to say is, if we are concerned with the geography of anything related to people, so that could be healthcare, it could be deprivation, it could be literally anything you can think of. What we conventionally work with, and this is true in pretty much every part of the world, is we work with data that treat the area of interest as though it's completely covered by people. So what I mean by that is, if we look at the top left, we have local government districts for Northern Ireland, of which there are 11. So if we look at Mid-Ulster, for example, if we attached population information or health information to that area, kind of the implicit assumption is that people are spread evenly across the area, which is obviously not true. We know that there are population centres, and that's where most people are located, particularly in the more rural areas of the west of Northern Ireland. We find, obviously, that people are very much spatially concentrated into very small areas. Even if we use something like super output areas, of which, as I've said before, there are 890, you can see that these are very small in places like Belfast and Derry, Londonderry, and other urban areas, and they're very large in rural areas. So if we were looking at accessibility, ideally we would know where people live, particularly within these rural areas, because if a population concentration is in the far west of a region, but our facilities in the far east, then we have a poor mismatch. So often we don't have any choice but to use data like this, for which you tend to have smaller areas with areas of more dense population, and larger areas with areas of low density population. So often it's the best we can do, but it's not ideal, particularly if we're looking at spatial concentrations of need and accessibility, especially outside of those densely populated urban areas. So one of the things that we have in Northern Ireland, which is quite unusual internationally, is that we have grid square data, and we've had those since 1971. So every census, of which obviously the latest is that they've started to release some of the outputs, has produced a variety of population characteristics by these grid squares. In Britain, for example, they did this in 1971, but then they stopped doing it, and they're only doing it again this time round for the most recent census. But Northern Ireland, with much more foresight, continued doing it. And so we've had these data, and we can look at things like population change and changing population densities from 1971 onwards. So these are 1 kilometre grid cells. I'll come to this in a bit more detail later on, but the important thing to point out is, particularly if we look at rural areas, like if we look at the mountains of Mourne or the Sperrins or some of the rural areas of the west, we don't have grid squares where there are no people. So rather than completely covering the areas of land as we get with super output areas or wards or census tracts, in most cases, instead we've got gaps. So we've got a much more spatially nuanced way of looking at where people live, and therefore potentially of looking at need. Okay, so this is potentially a really much more useful way of doing things. The problem, as I will say a little bit later on, is that we have census data for grid squares, but we don't have other data sources like administrative data, the multiple deprivation measure, or whatever else. But one of the minor points, I suppose, well, actually not that much of a minor point, I will stress as we talk, is that if anyone anywhere in the world, including the whole of the island of Ireland, is interested in accessibility, then something like grid squares are much better suited to thinking about accessibility than our standard geographies. So, you know, there's a kind of call I persistently make that if it's possible to release data by grid squares, then that would be a good thing. So just to show in a little bit more detail some examples. So we're looking at the southwest, obviously. You can see the outlines of grid squares superimposed on some of these super output areas. So I should say that the grid squares with the full array of data, so things like health conditions or housing tenure or whatever, are only released where the population is above a certain threshold, or the housing numbers are above a certain threshold. So you don't get anything below those thresholds. So there is a weakness. You do get total population and total housing for every single grid square, but not necessarily the breakdown of all those other characteristics like age or tenure or whatever else. But the key thing to point out is this is already showing us that the populated areas are geographically concentrated within the super output areas. So if we want to look at need and the distribution of health or healthiness or any other population characteristic, this is a much better way of doing it if we can. So let's take a step back. So irrespective of the geographical units that we use, we were interested in dementia rates. That was our starting premise. Now, in Northern Ireland, we have data on dementia patients, or people living with dementia, I should say, by GP practice. That means that we can map those locations and we can look at where levels are high or where they're low, but they're linked to the GP practice, not to where somebody lives. So obviously some GPs, some general practice practices, I should say, I suppose, have very large catchment areas, and others have very small catchment areas, and you don't necessarily attend GP practice which is nearest to where you live. So it's in many cases a pretty poor fit in terms of the true geography of health conditions. We did manage to get from the Business Services Organisation, or the BSO, data on patients by GP practice and residents, but not by dementia as a diagnosis. So we couldn't actually map dementia rates by area of residence directly. We could only estimate it by using the GP-based data on people living with dementia, and then this breakdown of patients by GP practice and residents. So we had to kind of allocate it. So it was only an estimate, which in some cases might be fairly crude. So we were using super output areas in the first instance. So as I've said already, there are 890 of these in Northern Ireland. Population of those is approximately 2,100 people. But as I've already said, and I've just given you the example with the grid squares, is that in rural, sparsely populated regions, these aren't particularly helpful in terms of targeting resources, because populations may well live in a very small part of the geographical area which is covered by a super output area. So this is just an example of some of the data. So these are disease prevalence data for Northern Ireland by GP practice. And we've got a practice ID in column A, practice list size, and then we've got population breakdowns by age. And then we've got number of patients on the register, and included among those is dementia. And you can see, if you can see the tabs along the bottom, we've got these data for various years. So we can look at changes in practice, provision of practices, and those that are still there or not, and obviously the breakdown of health conditions. But as I said, this is not especially helpful if we want to think about access in relation to residents. Okay, it's really good to have these data, but they're limited for our particular purpose. So this is a map using super output areas. So 890 areas, as I said, average population just over 2,000. And in this case, it's linked to the locations of GPs. So it's not located to residents. So in many cases, there might be a mismatch. And some of the hotspots that we see, for example, those in red, which are particularly high rates, will be a function of where the GP practice is located, not necessarily where people live. Particularly if you look at somewhere like parts of Belfast, where it's very, very likely that people will not live in the same super output area as where their GP practice is located. Often they'll be traveling the border between areas, even though they won't necessarily know that they are. They will be doing that. So that's the most obvious thing we can do, but it is, as I've said, limited. This is an example showing the GP locations. So we've got these kind of turquoise coloured dots, which are GP surgeries from the October 2018 database release. And then we've got something called T's and polygons overlaid on those. So these are these black lines. So anywhere in this area, for example, I'm assuming you can see the cursor okay, are closer to the surgery that's in the middle of that area than they are to any other one. Okay, so this is a simple visualization of proximity to a GP practice in this case. And if you look at someone like Belfast or Derry, Londonderry, then you can see that there are many more. Obviously, you've got a higher density because your population's got a higher density. But in some of the rural areas, you could be talking about very large physical distances to reflect the much lower population density. So what we have tried to do, I've explained how the BSO provided data on GP patients by their practice and where they live, just not the breakdown by dementia. And using those data and then the number of patients or people living with dementia in each practice, we've made these estimates. So now we've got in the red the highest rates, and in the blues are the lowest rates. So again, this is a pretty coarse estimate, and I'll say a bit more about how we can do this better, and indeed some of you present might have better ideas or an awareness of changes in availability of data sources, but we'll talk about that later on. But for now, this is an estimate. So simply, as I've said, in the reds, our estimate is that the dementia rates are higher and the blues are lower. I should say this is out of the population age 65 plus, which of course is not including everybody with living with dementia. It's just, we tried a few different approaches with different denominators. I'll show you the example in a minute with the whole population as the denominator. But pretty obviously, hopefully, the way the rate's calculated is, if taking this example, if you've got 15 people living with dementia and 150 people in total, which obviously would be a huge proportion in the real world, you get a figure of 0.10. So we do get very large figures here, and a variety of reasons for that, one of which is that our denominator is probably not particularly sensible. Using only people aged over 65 is obviously not capturing everybody who might live with dementia by a long way. It's just that we're dealing with very uncertain data. This is using everybody as a denominator, so our rates go down. So our largest figure is in effect 1% if we included everybody, but that's not ideal either. So you know, there are a variety of different things that we could do, but these are best initial estimates. But I'll talk about some other approaches that potentially we could use in trying to look at these issues. So the data that we have on people living with dementia are for GP practices. Like I've said, there are a number of other publicly available possibilities that we could use. Now, the census in Northern Ireland, and the same will be true in 2021 as in 2011, which is the data that I'm going to talk about now, includes a question on something called limiting long-term illnesses, or LLTI. And in most of the UK, up until 2001, all you would get in relation to that question is whether or not you had a limiting long-term illness which restricted your ability to lead a normal day-to-day life a lot or a little. Basically, that's what you would get. But in Northern Ireland from 2011, that was expanded to include particular types of health conditions which might limit your day-to-day life in some way. So as you can see on the right-hand side, this is question 23 from the 2011 census in Northern Ireland, though, as I said, not in Britain. You could say whether or not you felt you had any of these conditions, or if they applied to you, and if they've lasted or they were expected to last at least 12 months. So you can read those there, but we've got a variety of things like mobility or dexterity difficulties, emotional, psychological, mental health conditions, and then one which is probably closest to what we'd be interested in, though again, it will include a large number of people who do not live with dementia, do not suffer from dementia, but it's the closest fit. So frequent periods of confusion or memory loss. I should say, of course, that these are not clinically prescribed categories for an individual. Well, at least that they are recorded by the individual. It's an individual's own perception. This is self-reported health. Okay, so it's quite different from something that relates to a clinical diagnosis. But nonetheless, it offers us a really rich, geographically rich data set that we can link to a whole host of other characteristics. So it's possible, for example, to think about how far mental health conditions, for example, at least as far as they're self-declared, relate to housing tenure or different forms of deprivation. So it's potentially a really useful, though very underutilized data set. So our estimates of dementia are clearly problematic. Clearly, we are averaging out the reality. Clearly, we're not capturing the geographical nuances that we know that are there. Clearly, we're not including everybody who we should be including. The best we can do is a very approximate, fairly localized guess of where there might be the highest levels of people living with dementia, and therefore where need for particular services might be greatest. And the census potentially offers a way of trying to enhance that a little bit. It certainly helps us to understand the geography of poor health in as far as people perceive it themselves, even if it's not related to a clinical diagnosis. So as I said, we've got this variety of questions. I'm not sure if they're exactly the same in the 2021 census, but they are pretty much. It's including more or less the same categories. So be able to look at how this has evolved on a geographical basis in the 10 years between 2011 and 2021. We'll be able to do that in due course, not yet. So as I said, much more detail here than in Britain, where none of these breakdowns are available. So it's potentially a very rich data set. So this is the percentage of the population who said that they suffered from frequent periods of confusion or memory loss. So our maximum value is 7.68%, which is in the band, the upper end of the band that's coloured red, and then our lower percentages are in the areas that are shaded blue. So You can see there are a few areas right across Northern Ireland, but with the biggest concentrations in Belfast and a couple in Derry, Londonderry, and a few in more rural areas where the percentages are much higher. But as I've got at the top here on the right-hand side, well, that's okay, but it could be that in some cases only a small proportion of those people who said that they suffer from frequent periods of confusion or memory loss are living with dementia. It might be a very small percentage, it might be a large percentage in other cases, so it's very hard to deconstruct. But nonetheless, we have this geographically rich data set, and as I'll say in a minute or two, these are also available for grid squares because it's part of the census. So we can look at this in a much more geographically refined way. So let's just say a little bit more about the grid square data. I am an advocate of grid squares, and I've been working with them for a long time. And I led a project trying to translate data for Britain from 1971 to 2011 from the standard geographies to grids, partly because they are really good for exploring change through time. But as I said, in Northern Ireland, we have these data. They can be used and downloaded freely from NISRA. So on the right-hand side is an example of one of these grids, and this is just population. So we've got, this is from 2001. So we've got 2011 data, and then hopefully soon in the next few months, we'll have 2021 data too. So we've got the lowest populations, and this is an artifact. There could be a grid cell with one person in it in theory. It's just that given the thresholding, the minimum figure that you actually get is a 3. So we get a minimum of 3, a maximum of 7,942 people in 2001. So this is literally a measure of population density because every single geographical area is the same. It's 1 kilometre by 1 kilometre. If you were to cut out those areas that had the full array of data, so not just the total population, but also had the breakdown by, for example, frequent periods of confusion or memory loss, then some of these grid cells would disappear. So you'd have more gaps for the reason that I've said already. There is a threshold that applies for which you do not get the full data set. But the same point stands, we've got holes where there are no people, so we can much better link where people actually live to proximity to services. Also, arguably, we can better look at spatial clusters of people with living with particular conditions in a much more geographically specific and targeted way than we can if we use super output areas or wards or census tracts or enumeration districts or whatever other geographical unit you might be familiar with. So we've got 1 by 1 kilometre grid squares. In Northern Ireland since 2001, we also have 100 by 100 metre grid squares. So we can look at this in a really, really geographically detailed way, but the thresholding means that we don't get the whole population. So the smaller the grid cells are, the more people fall out of the data set because they fall below the population and housing thresholds that NISRA apply. So grids are good for the reasons that I've already said. Partly, I think they're a more natural way of representing populations than wards or census tracts or anything else, because they show you actually where people are. They have holes where there are no people. So there can be gaps where there are no people. Also, zones like super output areas are based or were built based on the underlying population characteristics at a point in time. So if there's a big increase in population in a particular centre, a particular location, then the zone boundaries might change through time. If there's a depopulation in an area, then a zone might in theory disappear or be merged with a neighbouring area or whatever. Whereas grid squares aren't based on the population underlying what's going on. They're literally the same at all time points. So hopefully I'm starting to convince you that if you can get grid squares, they're a good thing to use. So as I said, the project was concerned with age and aging. So this is a map of the percentage of the population in 2011 who were aged 75 or older. So I emphasize again that age and aging are not the only facets of concern if you're interested in dementia, but it's something that's fairly easy to capture and that we know is an important element. So it makes sense to focus on it. So the blues have a very small percentage of the total population being aged 75 plus, and the reds have a very high population. As you can see, it's quite geographically noisy. So if we were to map the same characteristic for super output areas or something like that, then we might find that the patterns looked a bit neater. But because these are so small, the geographical areas are so small, it looks quite noisy. But better to have that and to understand that the fact that there isn't really geographical homogeneity, I think. So that's age 75 plus. And this has changed from 2011 from 1971 to 2011. So the areas in red tend to have larger percentages, and the areas in blue tend to have smaller percentages, or a decrease, a percentage point decrease in the population aged over 75. Another thing that we can do is to look at spatial clusters. So, because we've got grid squares, we can look at spatial clusters of older people, areas where populations might be aging, or where there are particular health conditions. So, for example, where do we find geographical clusters, significant clusters of older people, which have limited access to certain healthcare facilities? And we can highlight areas, for example, that have older people, but neighbouring areas which also have older people, so, or spatial outliers as well, so areas that have high rates neighboured by areas with lower rates. So here's an example. This is change in 75 plus as a percentage between 1971 and 2011, and the light blues are areas where you have decreases surrounded by decreases, and the reds are increases surrounded by increases, for example. So on the north coast here, for example, we've got a significant cluster of increases. This is obviously quite a long time span, 1971 to 2011, so it might be more useful to look at smaller time points, but the idea is you can at least identify areas where we see a significant increase in the proportion of the population who are older. So here's confusion or memory loss again as a percentage for super output areas. You've already seen that, and here it is for the same map, this time for grid squares. So this time we see a far more geographically nuanced picture. So if I flip back, if I flip between the two, it doesn't help if they're not exactly the same size, the maps, but you can see that some of these super output areas, which appear to be homogeneous when we use super output areas, are actually really not homogeneous. There's a lot going on inside them that means, you know, if we were trying to target resources based on the entire area, we might not be doing a brilliant job of it. Often there's nothing you can do, but ideally it would be better to spatially disaggregate these areas. And then these are clusters of people with frequent periods of confusion or memory loss. So we get here, these are high clusters. So these are areas with high rates surrounded by high rates, for example, and the blues are low rates surrounded by low rates. So you can imagine using these kinds of sources of information to better think about where need is most geographically concentrated. This is confusion and memory loss over everybody aged over 75, which obviously isn't going to include everybody. As a result, you get percentages of more than 100, which obviously doesn't make any sense. But it's making the point that your denominator is really important, obviously, and you have to think carefully about what it is you're trying to capture and whether or not actually looking at the whole population is sensible, or whether or not you maybe try to use some subset. So on the left, we've got a map of significant clusters for those aged 75 plus in 2011, and on the right hand side is change between 2001 and 2011. So again, these pinky colors, for example, here are places where there is a significant cluster of localities with an increase in the percentage of population aged over 75. And this is superimposing GP catchment areas. This is the map that I showed you earlier. So if you've got any grid cell that's in a particular boundary of one of these green areas is closer to the GP surgery at the center of that area than it is to any other one. So it's a way of starting to integrate the data sources. Just to move on quickly, I don't want to run out of time before we move to any questions that anybody might have. But one of the other things we did was to roll forward, to use change between 2001 and 2011 to try to estimate population increases or decreases for those aged over a certain age threshold. So aged over 75 here, for example. So this is an estimate of the increases or decreases in the population aged 75 plus between 2011 and 2031. It's only an approximate thing, but it's numerical, it's not percentage based. So in these parts of South Belfast, for example, you can see a numerical increase in those aged 75 plus. In other areas, there may be a numerical decrease or only a very small increase, which is what's represented by the kind of greeny turquoisey shade. So it's about trying to pull together a variety of different data sources on, in this case, dementia, though not particularly adequate estimates, need, area characteristics, so that could be deprivation, housing, transportation, and then trying to bring those together to create some kind of collective way of considering those factors together. So we've created an index that I'll come to in a minute, which people often do when you're trying to look at multiple characteristics. Here's one of the other inputs. So this is distances to GP surgery. So rather than using these catchment areas, this is literally a geographical straight line distance. You can use road distances or whatever. So the red grid cells are far from a GP surgery and the blues are close. Obviously, you'd expect that given the density of the population, but nonetheless, that's one bit of information you could obviously use if you're thinking about accessibility. So we've created a very provisional version of something we call the Index of Statutory Services Access. So you've got grid codes, which is what each row corresponds to. You can incorporate things like population density and Z scores, so relative measures of the population aged above 75, for example, or change in those populations. Variables like confusion or memory loss, distances to GP surgeries, pharmacies, dental surgeries, and so on. And these can be combined in a variety of different ways, as it's done with deprivation measures, such as the multiple deprivation measure, to create an overall index. And there are a few different sub parts of the index that focus on age or age and distance or whatever. And this is very much a work in progress, but it's a way of collapsing down multiple variables, and it can be adapted depending on an individual health condition or a particular type of health facility, as a way of identifying perhaps those areas that have the biggest concentration of need. But I can come back to that later if you're interested. So in the remaining time, we've got this web-based mapping resource that lets you look at data for super output areas and 1 kilometre grid squares. We've got these estimates of dementia rates that I've talked about, and also a variety of census-based variables, including this people living with frequent confusion or memory loss, age profiles, deprivation, etc. We've got this index of access to healthcare resources, and then these projected age profiles, but also healthcare facilities and background maps. Like any online geographical information system, it does the obvious things like letting you view several layers, pick layers of interest, click on those features that you're interested in, zoom in and pan around, as I've already said, extract characteristics of individual areas. So I'll show you it live in a moment, but things it can be used to do. This is an example of frequent confusion or memory loss with GP locations superimposed. You can obviously at a simple level identify single variables where rates are highest, if you're looking at change through time, where older age groups are projected to grow fastest, where access to core resources is poorest, according to whatever criteria you pick in your particular case, and where demand is likely to grow. If it becomes a useful tool, then obviously individuals or groups should be able to use it to say what facilities are available within an area. So as well as saying what's not there, you might say what is there. This is the index that I've talked about, and this is a screen dump from the resource that I'll look at in a minute. But just to briefly say that the areas with red grid cells are those that have the highest need according to this particular index, and there are any number of ways that you could construct an index depending on your criteria. And those areas that are in blue have the least need, and that's partly accounting for geographical proximity to particular services, but also the age profiles of areas in this very specific case. So we'll have a look at the resource now. I'm just quickly checking how long we've got. So we've got enough time, I think, to have a look at it. It will enable you, as I've said, to look at these geographical areas and the index and projected profiles and a variety of other things. So what I'm going to do is leave the presentation for a moment, and hopefully you can now see a screen in front of you with a map of Northern Ireland. And it started off with distance from GP surgeries. So as I've said, with the screen dump that I've shown you, you can see the categories on the right-hand side. The reds are grid cells that are very distant from a GP surgery, and the blues are those that are less distant. On the left-hand side, you can see the characteristics that are included, and I've turned some of those off. You can access the slides to the presentation, and I've included the hyperlink, so you can look at this if you want, and I would invite comments or questions or queries on that, both now but also after the event if you have a look at this. So you can see layers that are turned on or turned off. So the icon with the eye through it indicates that a layer is turned off at the moment. If I turn that back on, there's GP surgeries, for example. So you can now see those. Obviously, they're at the center of these distance shades, so that they're near the blue grid squares, because they are obviously, that's where the GP surgeries are located. We've got pharmacies, dental surgeries, GP catchment areas, which I've already shown you. We've got the grid square data on age above 75. You could easily include that for other time periods. We've got change through time from 2001 to 2011, projected change, which I'd already talked about a little bit. There are other variables that might be important. If you're thinking about the implications of a lack of access to resources for certain healthcare facilities, then a variety of different deprivation characteristics might be important. So it could be, for example, that unemployment, for example, as one facet of deprivation might reduce somebody's chance to access certain types of healthcare facility depending on their life stage, etc., etc. Other health-related variables that we included, and there are many others we could include the percentage of the population who are undertaking unpaid care for more than 20 hours or more per week. There's another question in the census on bad or very bad health. It's a general health question. And then this one on confusion or memory loss, which I'd already talked about, which we've included, and a variety of other characteristics that are included there, including this needs index. I'm just trying to think what else I could usefully say. So you can click on an individual area depending on the layer that you've got highlighted at a given time, and it will bring up the attributes to that particular area. If you want to see what's going on underneath with a particular layer picked, let me pick I'll pick distance from GPs and turn off all the others. Where are we? There we go. And then you can make the layer transparent and zoom in on whatever it is you're interested in to try and see what's basically going on underneath. But again, to make the point about grid squares, the fact that we're properly seeing gaps where we should. So in the Sperrins, for example, here we haven't got any people because either there aren't very many and they're below the threshold, or there's literally nobody living there. Whereas if we were to use super output areas of some kind, super output areas or other zones like wards, this entire area would appear to be populated. Okay, so I'll come to how this could be expanded. At the moment, it's a fairly basic resource that includes just a limited number of layers, but there's potentially much more that could be done. So I will finish off with the formal part of the presentation while we've still got a few minutes. So the ways that we could go forward with this, several things we could do in relation to health conditions, obviously moving beyond the GP-based data and moving to real residence-based data would be preferable. There's an initiative going on in Northern Ireland at the moment called the General Practice Intelligence Platform. I'm not sure what the absolute latest stage is with that, but that offers a potential way of accessing detailed information. There's also the Honest Broker Service through the BSO, which is another way potentially of accessing healthcare data. So they would need, those sorts of initiatives would need to be the basis of a proper geographically detailed assessment of health conditions across Northern Ireland. Ideally, these data would be for grids or some other kind of geography that doesn't assume that the entire area of the zone is equally populated, if you like, which it isn't. We can update it using 2021 census data and on health and other conditions. We'll be able to do that very soon. Other healthcare services, we've got GPs, dentists, pharmacies. We could obviously include other forms of support or primary care, like hospitals or certain types of hospital departments, funding locations. And I've already talked about the Public Health Agency project that I'm engaged in at the moment, which is looking at gaps in funding. Other lower level services, like in the case of dementia, potentially memory clinics or community groups could be included. And the original vision of this project was that people would engage with it in a variety of different ways and contribute information which is added so that it becomes actually useful rather than just being an academic resource. Also, very briefly, in my last not very many minutes, I just wanted to say something about potential ways of expanding. So we could promote this particular tool amongst groups concerned with dementia and living with dementia, but obviously it could be generalized. And the key aim is to develop a resource that is focused on accessibility to and the need for services and support. Of course, it could also extend across the border because, as I've said already, health and healthcare doesn't stop at the border. Really quickly, I think it's worth pointing out one of the sorts of things we could do. There's a resource in Britain called AIIHPC, or the Index of Access to Health Assets and Hazards. And it includes information on access to retail outlets like fast food, but also health services, also air quality like green space, air pollution, and access to natural environment like green spaces. There's an example of the platform that does it. A similar thing like this in Northern Ireland, and indeed the whole of Ireland, could be potentially quite a useful resource for thinking about either access or impediments to good, healthy practices. So that might be something that can be considered going forward. My final slide on the acknowledgements is just to say, if this is the sort of thing that would interest you as a particular type of user, if there's a geographical distribution of health conditions or resources that is of interest to you, then I'd be interested to hear, because it all helps to build up an agenda to do this properly and to really try to tackle the issues around access to data, but to include resources that actually should be included and to make it something which is actually genuinely useful. Also, as part of future plans, knowing about needs to understand GIS and spatial data is something that would be quite useful as well as a part of building a wider approach to handling geographical information around health. So finally, just to acknowledge the wider project team, Gemma Cagney, Nigel Hart, Lucy Hodkinson, who are all members of the wider project team, and I've already acknowledged the funders, also Sue Hun and others who are related to the DARUG initiative for support and for ideas about the project in the past and up to now. So thank you very much for your attention. I will stop there